I wanted to welcome Dr. Peter Bernstein today. He's coming to us from Albert Einstein College of Medicine and Montefiore Medical Center, but also from the American College of OBGYN as a representative for the Safe Motherhood Initiative bundles, the hypertensive disorders in pregnancy, the prophylaxis, and the postpartum hemorrhage. So review those bundles, and this is our opportunity to get some education about them and also ask him whatever questions we have as we've been rolling them out in the past year. Thanks for coming. And Dr. Bernstein is also sitting on the executive committee for District 2 for the college together. So it was a meeting last week and some good stuff occurring at the legislative committee level. So we can talk about that later if anybody wants to know more information. So I'm excited to talk more about, I told him last week, the prophylaxis issues with heparin, what challenges we've had in the hospital in trying to implement it universally. So.
Sure. Well, thank you for having me. It's not a very long talk. This is about the other bundles, but the talk that I brought with me is the one on venous thromboembolism prophylaxis, risk assessment and prophylaxis. So get this working. So venous thromboembolism is a cause of maternal mortality in the United States and around the world. It's one of the leading causes, and it happens to what appear to be young, healthy women, result in severe morbidity. And it's something that's amenable to prevention, and prophylaxis isn't that hard. It's something that can be implemented systematically and have a big impact. And this is evidence-based. It's been shown in the UK. There's been a dramatic, they implemented the prophylaxis guidelines for obstetrical patients and had a dramatic reduction. It was their first big success. They had a dramatic reduction in the number of maternal deaths as a result, and it doesn't take a lot of resources to do this. So in any of these bundles are taking a group of evidence-based interventions and putting them together and making sure every patient gets them every time. So you need risk assessment tools. You need to decide who needs the bundle. You have to have protocols for them, both postpartum, antepartum, and postpartum. I'm going to show you a suggested dosing schedule. There's a lot of I think that it's a little bit overblown, but a lot of controversy around anesthesia and VTE prophylaxis. And I'll also give you some references, and we'll talk about some of the key papers. So all patients should be assessed for venous thromboembolism multiple times during the pregnancy because their risk of VTE changes over the course of a pregnancy. So it should happen when they present prenatal care. It should happen during any hospitalization for an antepartum indication. It should happen when they're admitted for delivery, especially when they're postpartum, since that's one of the highest risk periods for VTE, and also should be thought about when the patient is going home. And prophylaxis can be based just on risk factors, or it can be empirically given to everybody with a certain It's a quality measure that the Joint Commission is looking at. Up until recently, it was a quality measure that wasn't applied to obstetrics, and now there's talk of applying it to obstetrics as well, but it's something that's applied throughout the hospital. So the states that all patients should receive VTE prophylaxis or have documentation why they weren't given VTE prophylaxis within a day of their hospital admission or within a day of surgery. Okay. Risk assessment tools out there, we're going to just talk about one of them. From a variety of sources. These were what we put together in this bundle for District 2 ACOG was based on guidelines from CHEST, and we College of Chest Physicians and ACOG practice bulletins. So the patient and postpartum discharge prophylaxis guidelines were based primarily on what comes from chest and from the ACOG recommendations. The inpatient prophylaxis guidelines, since ACOG hasn't put out anything formally, we took that from the Royal College of OBGYN, where they've had dramatic reductions in maternal mortalities as a result of VTE. And these pharmacologic prophylaxis may be with unfractionated heparin or with low molecular weight heparins. Assessment during prenatal care, women who've had, this is based on their history, women who've had multiple episodes of VTE or have high-risk thrombophilia syndromes or an acquired thrombophilia syndrome and a VTE. Those are women who should get full anticoagulation with a low molecular weight heparin or an unfractionated heparin during the pregnancy. Women with idiopathic VTE or VTE that happened during pregnancy or while on oral contraceptives, or those with a low-risk type of thrombophilia, or a family history of VTE with a high-risk thrombophilia or high-risk thrombophilia but they never had a VTE, those women should get prophylactic dose, low molecular weight or unfractionated heparin. And those women who have a history of one VTE but no thrombophilia, or a history of VTE with a low-risk thrombophilia or a low-risk thrombophilia in a prior event. So these are the categories, and those women don't need treatment during the pregnancy. These materials are all downloadable as posters and chart things and such like that, so you don't have to memorize this. Low-risk thrombophilia are women who are homozygous for the factor V Leiden or the prothrombin gene mutation.
Let's go back to the slide.
Sure.
So the second family history, is that first relative?
Yes.
The last talk, VTE provoked. VTE oral contraceptive, isn't that the same thing as VTE provoked? No.
Provoked would be like had on their leg for a prolonged period of time and developed a clot.
Okay.
So what the low risk and the high risk thrombophilia are factor V Leiden or prothrombin gene mutation where they're homozygous, if they have antithrombin 3 deficiency, or they're a compound heterozygote for the factor V Leiden and the prothrombin gene mutation. A low risk is if they're heterozygous either for the factor V Leiden or prothrombin gene mutation, or they have protein C or S deficiency, and of course acquired thrombophilia, the antiphospholipid syndrome. Right. For homozygous or heterozygous or both?
Both.
For heterozygous, I don't believe there's any evidence for that at all.
Right.
Homozygous, I think, some evidence. That wasn't included in the ACOG statement. I didn't hear what you said. I have. Certain, none of the, except for the antiphospholipid, these lap a little bit with people send them for women with recurrent pregnancy loss or plain and fetal demise. And I have completely stopped sending all of them except for the antiphospholipid syndrome.
And the PAI.
PAI-1 and
coming up.
Right. Again, not addressed in the, we're getting into new areas and it's not in the ACOG practice bulletins. So I would consult with a hematologist about their risks related to thrombophilia and thromboembolism.
We usually in our practice Pisco had two patients. One is a young girl who's 17 who had a very large femoral DVT with a workup that was only positive for homozygous for the MTHFR A1298C, and a primary family member with a history of clot. And then we had a pregnant patient who had a large PE, and her workup also only homozygous MTHFR A1298C, and a family member with a history of clot. So we haven't found anything else, so it's kind of frustrating, you know. So
right, well, sometimes these are idiopathic and we don't understand where they come from. And I think, you know, this is an emerging science. I mean, they find a new gene that's associated, you know, and but what's been studied right now is what's on the slide. Remember, these are all guidelines and a careful note saying, you know, given this gene that may or may not be and this strong history, you know, I choose to do X, Y, and Z is perfectly acceptable. Or choose not to because she had a cast on her leg, and so I don't really think it was this. And so the risk is pretty low that it'll happen again. Now, these are the slide, and we don't need to go and spend too much time on this, but this is a slide that just talks about the prevalence and risks of VTE with the various thrombophilias, and I'll call your attention to the column all the way on the right, which is the VTE risk in pregnancy with a prior VTE if they have one of these genetic conditions. So you can see that if they're factor V Leiden heterozygous with VTE, they have about a 10% chance of having another clot. Okay, so provoked, this was your question before, provoked VTE is defined as an event occurring in the setting of a temporary risk factor that increases the risk. So that would be orthopedic surgery, for example, if they had an indwelling line and developed a clot in the area of the line, if they had prolonged immobilization for some reason and they developed a clot. An unprovoked VTE is one that occurs in the absence of temporary risk factors. Now, provoked by estrogen, treated at a slightly higher risk for recurrence, guidelines for unprovoked VTE should be followed for patients with this history, because whatever that provoking, the reason why we've switched this category is because we're talking about during pregnancy, so the factor that led them to have a clot before is now present in the current clinical condition, and so higher risk. This would be as if they had a clot and they had their leg in a cast for a month, and now they've got their other leg in a cast for another month. Okay. The recommendations are, this is for an antepartum hospitalization. I'm not talking about, you know, this is admission for premature rupture of membranes, for example, and so they're staying here in your hospital for a while. All of these women should get mechanical prophylaxis or empirically be given pharmacologic prophylaxis. I'll tell you what we're doing is all of our patients get pharmacologic prophylaxis 100% of the time. We put it in order set so it becomes automatic. Our medical record can't complete the admission orders without being what the prophylaxis is going to be, or charting in the order set that they can't get it. You know, for example, if they have a bleeding disorder, and so you have to indicate why you're opting out. So for you, if you're choosing a risk factor-based way of doing this instead of doing it empirically, we recommending heparin if at least one of the factors below is present. If she's already being it as an outpatient, she should definitely continue as an inpatient. But other factors are pre-pregnancy, morbid obesity, or any history of VTE. And if there are more risk factors of these other risk factors, which are factors, that's young age, older age, a BMI greater than 30, if they're going to be on bed rest, if they have any thrombophilia. Medical conditions would be things like hypertension, which slightly increase their risk of thromboembolism. Pregnancy complications are things like fetal growth restriction. And on the ACOG website, you can download a for this from the District 2 website that outlines what all of these conditions and pregnancy complication risk factors are. So, but a growth-restricted baby may be a woman who, for some reason, is slightly hypercoagulable and therefore has placental insufficiency on the basis of that. And that's someone who should be considered for prophylactic, either molecular weight or unfractionated. At the time of delivery, all should have early mobilization. You want to avoid dehydration and provide chemoprophylaxis based on risk factors. Women undergoing cesarean delivery should receive sequential compression devices perioperatively and postpartum, and receive chemoprophylaxis either empirically or based on risk factors. And I'll tell you that in my patient population, so many women have a risk factor, I would say probably 80% of them, that we're moving to universal chemoprophylaxis after cesarean delivery. So it just makes it just a way of being sure that nobody misses it, and because we feel the risk of heparin is so low dose, we're not talking about therapeutic dosing, but prophylactic dosing. Because the risk is so low, we have moved to universal chemoprophylaxis post-cesarean delivery.
Out of curiosity, have you noticed an increase in hematomas?
No.
I already asked him.
Yeah, we just saw a rise in,
Yeah, we've actually lately noticed decline in our decision complications. You put these all together, so it's the wounds that open up, whether they're seromas or hematomas or infection, and we started, since we've started subcuticular closures or using staples that we have the visiting nurses take out at home or post-op day 7, we've noticed that our wound complication rate has dropped substantially. So I'm lumping all of our wound complications into one. And since we took that intervention, we feel that our number of wound complications has dropped dramatically.
For instance, to Murphy specified not on abdomen.
Giving it in the arm, and I don't know that we specify it, but I think our pattern has been they get it in the deltoid or the
Yeah.
not getting it in the abdomen.
Yeah.
The patient that's orbital and the motion at the same time on the
They don't have
We'll get to the epidural conversation in a minute. Yes, you can. As long as you have to be careful around those. But remember, we're talking about prophylactic dosing, and we're not talking about therapeutic dosing. So we're talking about 5,000 of unfractionated heparin. We'll go into the doses, but we're talking about 5,000 of heparin every 12 hours. Go by a risk factors system instead of empirically. Risk factors, we recommend heparin at least if at least one of these factors are present. So receiving heparin as an outpatient, this is basically the same list almost entirely. Receiving heparin as an outpatient, obesity, any history of VTE, or history of thrombophilia. 2 or more of these risk factors would be cesarean delivery, hemorrhage, hysterectomy, so it's cesarean hysterectomy, right, because these are women who delivered. General anesthesia, postpartum infection, extremes of age, obesity with a BMI greater than 30, anticipated prolonged bed rest, any thrombophilia at all, or pregnancy complications. And we do simple discharge. Now, a woman who's going home, the clinical history, based on clinical history, you should consider either prophylactic therapeutic anticoagulation. Women who've had multiple episodes of VTE or VTE with a high-risk thrombophilia or VTE with an acquired thrombophilia, those women should get 6 weeks of full-dose anticoagulation after they go home. Those who've had an idiopathic VTE or VTE while pregnant or on an oral contraceptive with a low-risk thrombophilia and a VTE, or a family history of VTE with a high-risk, and they have a high-risk thrombophilia, these women who should get 6 weeks of prophylactic dose and be provoked, meaning in a cast or something like that. The last two are what are two changes from the initial assessment, right? It's the same set of risk factors that you did for antepartum during the course of prenatal care. We've just added postpartum is a higher risk period, and so there are two additional risk factors added to this list, which is provoked VTE and a low risk thrombophilia with a family history of VTE. And if all they have is a low risk family thrombophilia but no strong family history or personal history, they don't need any treatment. Okay, so let's get into the weeds on which heparin. So there are advantages and disadvantages to low molecular weight heparin compared to an unfractionated heparin. A low molecular weight heparin has fewer bleeding episodes, risk of heparin-induced thrombocytopenia, lower incidence of osteoporosis for patients who are on it chronically, and it has more predictable pharmacokinetics. Factor 10A activity measurement is not required for low molecular weight heparin in women who are therapeutically anticoagulating, except for women who have extremes of body weight or have renal impairment. I will tell you that just to be on the safe side, we are women who are therapeutically anticoagulated on a low molecular weight heparin. We are monitoring their factor 10A activities levels. Okay, just so that they're on the appropriate dose of low molecular weight heparin. It has a longer half-life than unfractionated heparin, which has its advantage during the antepartum period because during prenatal care, because a woman only will dose herself less often, but it's a disadvantage in women who are getting close to the time of labor and delivery. Contraindications to low molecular weight heparin therapy are hemophilia or a known bleeding disorder, active or threatened antenatal bleeding such as a previa, and you have to balance this based on your clinical judgment, based on risks and benefits. If you're have a patient who's got bleeding, and they are on a low molecular weight heparin or an unfractionated heparin, you should consider holding it until they're 12 to 24 hours out from their bleeding episode. Shouldn't be given to a woman with thrombocytopenia, recent stroke, severe renal disease, severe liver disease, as evidenced by a prolonged ProTime, hypertension. Unfractionated heparin, of course, should be used if there's a specific contraindication to the low molecular weight heparin. You have to worry about heparin-induced thrombocytopenia for women who are anticipated to be on it for greater than 7 days. So you would look at a CC at about 7 to 10 days after initiating heparin, any of the heparins. And a platelet count of less than 150 or an acute drop of 50% should require further evaluation and consultation with a hematologist. They have a preceding diagnosis of gestational thrombocytopenia, or ITP, that can be a confounding thing for HIP, and you want to get consultation from a hematologist. Okay, for women on a low molecular weight heparin, you should probably, we do, switch them to an unfractionated heparin at 35 to 36 weeks to facilitate regional analgesia when they come in labor. Patients who are transitions from low molecular to unfractionated heparin need to remember not to forget this is a different formulation. You need to worry about HIT again. Here are protocols for the different low molecular weight heparins. Again, based on body weight, I will say that during pregnancy, the placenta, one of the reasons why we're monitoring anti-Factor A levels is because the placenta loves heparin, and it often takes a higher dose to get a therapeutic. And so we initially treat, when we're using unfractionated heparin, we're using 7,500 Q12 on everybody. But here are regimens for the different low molecular weight heparins for prophylaxis and for fractionated heparin based on maternal body weight. Questions about that? Decision to use 7,500 compared to 5,000 routinely not based on any hard evidence. It's just based on sort of expert opinion and the physiology of pregnancy. But the literature is the 5,000, and that's more extrapolated from the non-pregnant patient literature.
Was the 5,000 was the chest recommended?
Yes. Therapeutic dosing, these are the dosing regimens for the low molecular weight heparins and the unfractionated heparin. And if you're using warfarin in the postpartum period, by using warfarin during pregnancy.
Have your attention, please. The fire system is disabled at this time. For emergencies, please dial 711. May I have your attention, please? Alarm system is disabled at this time. For emergencies, please dial 711.
Okay, so here's where we get into the more controversial part, and that's the timing of neuraxial anesthesia. For who are on less than 10,000 units of fractionated heparin a day, there's no contraindication performance of neuraxial blockade. And they're on therapeutic doses of unfractionated heparin, you should probably wait at least 6 hours after the last dose or check a PTT. On low molecular weight heparin, that's a prophylactic dose, you should wait at least 12 hours after the last dose before providing a regional anesthesia. And if they're on a therapeutic dose of low molecular weight heparin, you need to wait 24 hours at least after the last dose prior to providing anesthesia. In the postpartum period, recommendations are to wait at least an hour after an epidural catheter has been removed or a spinal needle has been placed in before giving fractionated heparin prophylaxis. If they need to be in therapeutic, you're going to probably want to wait longer, but at least an hour. For low molecular weight heparin prophylaxis, you want to wait 4 hours, and if you're going to be doing low molecular weight heparin that's therapeutic, avoid therapeutic dosing with the catheter in place and wait at least 24 hours after the catheter has been removed or the spinal needle has been removed.
More time, regardless of regional anesthesia, to give it post-delivery.
Prophylactic.
Let's say you didn't have a regional. Let's say you went to sleep, general. When do you want to give them this? What is the best time to afterwards?
So for prophylaxis, you can give it immediately.
Immediately. But it should be done immediately or a few hours after? What is the best?
if it's just a vaginal delivery without a 4th degree repair, wash the delivery room, right? I mean, the uterus is the uterine bleeding is primarily stopped not by clotting, it's stopped by uterine infections. Probably an hour. I mean, if you're doing prophylactic dose, you do it even with the laceration, you can go pretty quickly. You know, within an hour, make sure that they're stable and you're not going back.
So here we use postpartum protection, continuous epidurals afterwards, patient-controlled epidurals. So we unpracticed prophylaxis, the epidural in. So would you need to wait 1 hour or not? Because it's therapeutic.
So an interesting thing that comes up is in the general surgery literature, patients get it prior to surgery, right? The thing that I find a little confusing about this is your timing of the dose. If you give the dose, it's actually an hour or two afterwards, 2 hours afterwards, that the medication their bloodstream. And so this is a little bit made up. So in surgery literature, they get it on the table before surgery. It's hitting their system 2 hours later, maybe while you're in the middle of your surgery, and prophylactic dosing doesn't have any impact. So I give it prophylactic dosing. I mean, I'm probably using an unfractionated heparin, not a low molecular weight heparin in this situation, but I really think that there's very little risk with a prophylactic dosing of an unfractionated heparin.
We decided at this hospital, we had a sort of with a representative from each one of the participating groups, using only the unfractionated heparin as opposed to molecular weight heparin, only for ways so everyone's on the same page and decrease the risk of complication errors.
Right. Protocol.
By having one.
Have you unfractionated? Okay.
100% of C-sections get it as part of their postpartum orders. Started in the recovery room.
And 10,000?
5,000.
Yeah.
And then do you continue to epidurals afterwards, or are you doing dermal?
We're doing a small number are getting continuous epidurals. Most are getting dermal.
So the most controversial thing that we have here, as everyone here knows, is there are people who like continuous toradol use on top of it. And from the procedural literature, we know with low molecular weight heparin, having a continuous epidural, and you shouldn't be adding toward any other NSAID. Just plain heparin is really not out there. We that we're not
in the setting of toradol.
In the setting of toradol, we have done it because we're so concerned about it. Reference on your part.
I don't have any reference on that off the top.
So your institution,
sorry,
they're using toradol also?
Well, yeah, Durmorph.
We're getting Durmorph. Our patients get Durmorph.
But they're on toradol.
Well, theoretically, if you have a continuous epidural, you
shouldn't need it either, right?
Especially around the clock. Maybe one dose might be necessary, but not around the clock.
Right.
The thing I don't know, because people have been putting it on around, so we don't know if the patient needs it in the first place, or we're giving it to them because it's around the clock, or they're just so used to giving it to them.
That will change.
Right.
Do that again.
Right. They will forward all. Be very to it.
So this gets into this a little bit more. Post-cesarean prophylaxis. Receive the first dose of meeting criteria for PACU discharge no sooner than 1 hour after the epidural has been removed, and 5,000 every 12. That's what's recommended in the ACOG bundle. And if the epidural catheter remains in situ for pain control, it should be removed until 3 hours after the most recent dose of unfractionated heparin.
Yeah.
And if you're using it intraoperatively, should be given no sooner, any sooner than 3 minutes. Should be no sooner than 30 minutes after the spinal or the epidural. So occasionally, we're anticipating it's going to be a long case. It's a planned cesarean hysterectomy or something like that. For post-cesarean prophylaxis, if you're going to use low molecular weight heparin, first dose should be no sooner than 6 hours postoperatively, regardless of the anesthesia technique. And if an epidural catheter remains in situ for pain control, it should not be removed until 12 hours after the last dose of the low molecular weight heparin. Epidural catheters to be removed prior to a dose of low molecular weight heparin. Wait 4 hours until after the catheter removed to initiate the low molecular weight heparin.
So on the second bullet there, it comes what you're talking about. Either the presence of the epidural catheter with or the removal. That is when well, the image is the actual trauma of removing it. So that you can have the medicine ongoing if the catheter is just there. But to any movement of the catheter in the setting of amputation, they're concerned that there's increased risk of epidural hematoma. The second question I have then, is it more the timing instead of just the presence of the and the practice here is it's not being moved until 12 hours. And that's what we do in our hospital. No, I understand, but just in terms of the discussion that we're having before, so we can all get on board with the same thing, because it's medicine problem and make sure that guideline, we do not remove it. We remove it in the morning. They normally get their dose at night, so we wait 12 hours before. That's been ongoing. No. What we're saying is we're starting, even if we're starting at 6 hours, or if we're starting it in the recovery room.
Yeah.
Are your docs coming in and counting 6 hours or 12 hours for whatever medication that we use after that last dose? No. Normally what we do is we'll either remove it in the morning or in the evening, and what we'll do is we'll make sure it's at least 12 hours from the last dose
of low molecular weight heparin.
We got the heparin last night. The morning dose will wait and do it. We haven't been giving it in recovery.
But you're using unfractionated heparin, so it's a different. This is the low molecular weight heparin. You're unfractionated.
It's not forgiving. It's like 6 hours to 4 6 hours. No, but the reason why I bring it up because you lump things together. You all lump heparin together. So I can heparin. Really, we have to only have heparin here. Nobody's using low enough.
Post for unfractionated. So unfractionated, you have a much shorter time interval that you need to wait between the manipulation.
Yeah, we have.
If you're using low molecular weight heparin, the timing window is much wider than when you can manipulate the catheter.
And sure, actually on the third bullet actually says 2 hours is sufficient, not 4 hours. So we'll by your recommendation, but the anesthesia ASRA guidelines actually say that you can give that following dose after removal 2 hours.
By the way, we had anesthesiologists on this group, right? Smiley is one of the authors of this from Columbia.
So once you remove the catheter, how long do you have to wait to give the next dose of heparin? 2 hours? Okay.
Yeah.
30 minutes after the dose of the heparin before you remove the epidural, but then once you remove the epidural,
3 hours after the last dose to remove it, 30 before your next dose.
Okay.
Yeah.
Is that anesthesia department aware of, like, oh, I remove the catheter, the heparin dose?
Yes, we always ask in the morning before when they last gave it. Sorry. When we remove it, we ask when they last gave it.
And actually, when we had that meeting, one of the decisions about the heparin versus Lovenox, we had a couple of very difficult timings of Lovenox. And so we had anesthesia having to come back multiple times to try and do it perfectly. We didn't go through that work.
I don't know how many of you have been to the District 2 ACOG website and to look at the Safe Motherhood bundles, but when you go to the bundle on VTE prophylaxis, Donna has also posted the recommendations from the American Society of Regional Anesthesiologists, Regional Anesthesia, ASRA, and has put the ASRA guideline paper on the website to where you can download this slide set, because what we're putting in this slide set is exactly what the ASRA guidelines are. So this was done. We're not pulling this out of thin air, because I reread them last night, because they don't specifically talk about obstetrical patients.
They lump everybody together.
They lump everybody together. Let's see.
I had a question.
Yeah.
Right when I first came in, you were going over giving therapy to increasing INR or problems.
Right.
Do we have an issue with patients that you're ruling out for PIH? PIH to decide or not you should be giving this?
Well, if they're low platelets, there was a slide.
Yeah.
No, I'm just saying 75,000. I saw that.
Yes.
You actually have to wait till you get the results on those things, and also the liver function test prior to giving the dosing, because there was a liver function test.
Before, it's not the liver function. The liver function is dictated as evidenced by the PT.
Normally get PTs here on the patients.
So we're working on for. That's why I was just asking.
No, but very.
The PIH rule out, do we have to wait on the results, figure out whether or not it's appropriate to give population, or do we just say?
So I'll back you up a little bit. You're both right. It's thrombin, with Anesthesia, the typical transaminitis. If they have full-blown HELP syndrome and they are consuming platelets, then they're going to, so you're not going to see a long PT, and that's the thrombocytopenia, because really what's causing the prolonged time and the prolonged PT is the consumptive coagulopathy going up in the periphery and in the liver. So I can't ever think of some patient who had a normal platelet count and had a prolonged PT. Okay, so where was I? Okay, so postpartum, patients who require therapeutic molecular postpartum, you should define at least 24 hours after the spinal needle has been placed, the epidural catheter has been removed, and oxygenated dosing should also be considered. Unfractionated dosing in that initial period, depending upon her level of risk. You know, for example, we've had patients with heart valves and things like that, mechanical heart valves. If we're going to start the low molecular heparin, we've had a couple papers where we had hematomas, perineal hematomas, vulvar stuff in women who started their low molecular heparin a little bit too early after a delivery, who had a heart valve. So you really want to make sure that they're stable before therapeutically anticoagulate them. And so you should, but now what we're doing is unfractionated dosing, because you can reverse it if you need to. For patients with major risk factors for hemorrhage, you should consider either prophylactic dose unfractionated heparin or sequential compression devices. All patients require VT risk assessment multiple times during the pregnancy. All patients undergoing cesarean delivery should get mechanical prophylaxis, early ambulation, and adequate hydration. And women with additional risk factors after delivery should get prophylaxis. And we're suggesting that empiric pharmacologic prophylaxis for all women undergoing cesarean is an appropriate course of management, and also for all antepartum admissions who are estimated to be with you for more than 12 or 24 hours.
So from the inpatient facility, you switch from the anticoagulation only because
for patients.
Just you said all of your patients now basically get
they get SCDs